to talk about the presentation and the work that we started to do today. So when we started to organize this event, and as you have heard also from the previous speakers, one of the things that came up as very important was the way we deliver services. We have heard services, we heard primary health care, we heard the model of care. And of course, if we approach each one of you, the answer on what it is primary care or what it is a model of care will be slightly different. And this is what I would like to introduce now today. So if we ask patients or individuals in general what it is the model of care, you probably will hear that citizens will want to have services that are closer to their homes. They want services to be available 24/7. If you ask the practitioners, probably they will like to express the idea of working in multidisciplinary teams, to have flexible hours in order for them to take care of their own families, to have independence or autonomy, clinical autonomy. If you ask also the managers of these health facilities, then probably the perspective would be a bit different. They will want to see that their budgets are balanced, that they still with the resources available, they have the flexibility to allocate to the need of the population and so on. They need performance improvements in place. And finally, if you ask the policymakers, being these ones at Oblast Health Department level, but also at the national level, probably the perspective of a model of care is a little bit different. It will probably, the answer will be, well, we need to tackle equity issues. We need to engage in promoting and prevention of services in order for us to have a healthy society. So in the end, what we are saying is that all these different perspectives help to shape the model of care in a country. And that's what independently some of countries have done or have tackled in different ways. There is no one way, no one unique way to have answers to these questions. For example, in Estonia, they have a very good information system, so patients or people in general have access to their own health records, and they can consult, they know how much pharmaceuticals they have, they can contact their practitioners through their health records itself. But of course, Estonia is 1.1 million inhabitants, so we have to put things in perspective, right? Ireland made, for example, in order to have a home care at home, they discharge patients in a programmatic way. So community services, primary health care teams work with the hospitals in order to discuss together what is, and the patient and the family, in order to, to have a planned discharge so that people can go back to their homes, but still they don't disconnect from the services. In France, there is a very interesting experience born from a lot of women that are primary health care or family physicians, that they couldn't work full 8 hours, so they grouped and they created a model that is more flexible, so allowed the practitioners or the doctors to be together in the same teams, but at the same time they can work part-time. The way to communicate with the colleagues that he will enter in the next shift, it will be through the patient records. And we can go through different ways to different solutions that country has adopted. So in Israel, for example, the way to improve performance at the practitioner level was for managers to look at the statistics and to think in a more structural way what were those performance indicators that were shared by the managers of the facilities and the practitioners, the clinicians themselves. Italy and we will see later the Basque experience also, they adopted through new softwares that take into account the information not only from the health sector that we can gather, but also from other databases that the national governments have available, and they merge all this information in order for them to have a better understanding of the population, the needs of the population, the social economical status of the population, and based on those, then be able to target and to individualize services. Very interesting. I will not go more in detail. So what we are saying here is that actually, as we heard from our speakers, yes, we started in '78 with Alma-Ata Declaration as a milestone, but through all these years, we have been questioning and reflecting ourselves, what is the best model of care? We are challenged by many forces in order for us to rethink continuously as a dynamic concept. It's not static. What today is real here, probably in the next year, it will have to be reviewed. And that's why we are here today, and we are continuously worried and thinking and rethinking and trying to understand what other countries are doing. So the model of care, after all, then, is, like I said, is influenced by the population. First of all, the better understanding that we as health professionals have of the clinical aspects, the technology, the new pharmaceuticals, also the empowerment that we have in the last year created in our communities. So today, our citizens have the right to complain. And that complaint will go so up that we will be felt accountable for those complaints. We will be accountable for those complaints. So it is important also that to understand that these are new elements in our services. This was not like this before a few years. Many of us or our parents will definitely agree that nobody would imagine that we have that level of interaction, that we have grown so much, that now it makes our work so difficult as well, or so challenges, let's put it like that, but also very interesting. So perhaps I now move to what we try to do today in the next session is to take into account those perspectives. And we have invited, and I thank all of you from the Oblast, from my colleagues from different institutions coming from abroad. What we have tried to pull today is a little bit of international experience, or I don't like international, but let's say country experience from here and from there. We have tried to understand all these perspectives, right, from a patient perspective, from a practitioner perspective, what the managers will say. And those are the sessions that you see in the program today. And that's what we wanted to symbolize with this, group of 4 perspectives and 4 people, this puzzle that creates the model of care. It's only when we have all these perspectives considered and respected, involved, engaged, is that when we really have a model of care. And particularly today, we will see 4 oblasts, or actually 5 oblasts represented, but we have given a little bit more of a space at 2 oblasts where we have been very actively involved, and that is Mangistau and Kizilorda. But like we said, we have also many others. So this is the structure of the program and the next sessions.